Hi everyone on my Facebook. I'm going to be doing a talk right now on addiction to a group of naturopathic doctors. Here we go. So I am passionate about addiction, and let's just start it off by taking a look at what astrologically you should be addicted to. So this is always a good slide to start the topic. So any Cancerans out here? Netflix addictions? Anyone? So the agenda for today is I'll tell you a little bit about who I am and why I'm here. Our view of addiction in BC and Canada. I think there's a lot of information in the news now. We've got pretty much an endemic opiate crisis. I actually saw my first overdose on Hastings Street last week. It was a pretty intense situation. I was with a nurse practitioner at the time who actually jumped in and Narcaned the little kid up 3 times. That was a pretty scary thing to see, and it was real. It was actually real for me to see that. We'll take a look at what the stats say. We'll look at addiction as a disease, look at some options for treatment, and then something that I'm really passionate about is the stigma. The stigma and shame of addiction, because it's really what keeps people in the addiction and keeps them from asking and reaching out for help. And then I'll give you some addiction resources. My bio, I've been practicing for 13 years. This is my little girl Sierra. Had to put her down a couple months ago, so just kept that picture up there since I made this presentation. I'm an addiction recovery coach. I'm finishing up my addiction counseling certification right now. I'll be doing my practicum in January at Vancouver Detox. I'll be working with nurses and medical doctors and counselors to actually see how they medically detox someone. I'll also be working with facilitating some of the smart recovery meetings, which is an additional type of group similar to AA, which is non-spiritual based. And I also run something called Project Starlight. I do this with Gabor Mate's daughter-in-law, Tanya Mate, who is a fellow naturopathic colleague, and her and I have done 2 workshops already, and we're looking at bringing the workshop via webinar, and there'll be some information at the end of the talk about that for anyone who's interested in learning a little bit more about addiction. So my passion is helping other health professionals, teaching them that you shouldn't be ashamed about talking about addiction. If we look at our own lives, how many of you guys know a loved one, a mother, a father, a friend, a sibling who struggles with addiction? I think probably a lot of people do, right? I find a side benefit of what I do is really empowering families. So I'll get calls from family members who are interested in helping out their loved ones, and so I get a lot of joy of just connecting them with the right resources. And likewise with other colleagues of mine who just don't really know what to do, they reach out to me and I'm happy to do that. So please write my information down if you do have questions about this. Pretty connected in the addiction community within Vancouver, Surrey area. Disclosures, I'm at BCNA board. I'm also a CA&D board. I teach at Boucher. I've been teaching there for 10 years. And then the one piece that probably makes a difference is I just started working with Edgewood Health Network, which is a large network of private inpatient facilities throughout Canada. They've got Bellwood in Toronto and Homewood here and in Seattle. And I work in their intensive outpatient program. I'm the first one that's bringing in nutrition and complementary services into their training. So I'm really excited about that. If we look at mental health and addiction issues in British Columbia, 1 in 5 British Columbians will be affected by mental illness or addiction in 1 year. And only about 1 in 3 of those individuals will actually seek help. The fortunate thing is if those people seek help, 80% of them are actually going to find that help useful. So there's a problem. There's 66% of people that are struggling with mental illness and addiction that don't know how to reach out for help or are ashamed to reach out for help. And that's something that I would like to see changed. If we look at addiction in Canada, 1 in 10 Canadians over the age of 15 will be diagnosed with a substance use or substance addiction disorder in 1 year. So that's 1 in 10 Canadians. You may wonder what types of addictions are what we're dealing with here. You may think it's really the opiate crisis that's the big one, and it gets to all the news for sure. But it's actually alcohol and gambling are the 2 largest addictions here in British Columbia. So gambling is more of a behavioral-based addiction, but all the behavioral-based addictions work just like the substance-based. It's all a dopamine hit in the brain. And when it comes to neurotransmitters, which we won't talk a lot about today, dopamine is that key neurotransmitter. Just some additional stats here. These are a little bit older. The average cost that the government puts towards addiction is average about $1,500 per person if we were to actually divvy it out. 1 in 10 visits to the VGH ER are substance use related. What's really interesting is at the beginning of this year, VGH implemented a new emergency room that is just for individuals dealing with mental health and addiction services. So if you come in and you've got an overdose, you do not go to the regular ER where you're put in there with everyone else. You've got your own ER that you get to go with. It's a pretty cool concept. They also have a crisis team. So if you're in your office and someone is having a psychotic event in your office and you have no idea what to do you guys know where to call? Has everyone heard of CAR 87, CAR 88? Yep. Anyone, hands up? Pretty cool service we've got in here. If you've got a youth in crisis, call the operator, ask for CAR 87. You've got a psychiatric nurse and a police officer that will come to your location and they'll de-escalate things. They will assess and they can actually treat on the spot or even take them to the hospital. CAR 88 is for adults. The sad thing is they got one team. So if there's 3 crises in a day, they go to the first one that's been called. 30% of people diagnosed with a mental illness also have a substance use disorder. And we call that a concurrent disorder or a dual diagnosis. And that's a huge thing. Because did you know that if you are addicted to substances, you cannot get a psychiatric diagnosis in this province? Well, anywhere really. Which means that you don't get a diagnosis, which means you don't have access to services. So if you're someone struggling with a heroin addiction for 20 years and you may have some schizophrenia, a psychiatrist actually cannot diagnose schizophrenia because that's an exclusion, because how do you know it's not the substance? There's only one team in Vancouver that actually works with that. And they're based out of the Pennsylvania Hotel, and they will work with individuals that have a long-standing addiction history and that need support, and they've got 18 beds. There is a wait list 3 years long for these services. We've got some amazing services available for people, but there's a huge wait list. Things are changing though, which is great. One thing that we don't think about is how do you know if you're mentally well? How do you know if you're mentally unwell? And if we look at mental health as a spectrum, we look at a few aspects of that. And if you went to the Canadian Mental Health Association website, the CMHA website, you'd be able to do a questionnaire. You could do this with your patients in office. And what it looks at is it looks at a few key things. The one thing is the ability to enjoy life. So someone who is mentally well is able to get joy out of life. They're resilient. I don't think there's something more better you could say to someone that's sitting in front of you that's been through shit, and you look at them and say, wow, you've been through so much, you've got a lot of resilience. That shows a lot of strength in someone. If you can recognize that resiliency in your patients, they'll actually establish a better rapport. Balance, this is one that I struggle with. I think balance is probably the one thing that if I let go, my life will collapse. So balance is not working too much, making sure you've got enough time off, not pushing yourself to the extreme. Self-actualization, the ability to see yourself in the future as someone or something else, doing something you enjoy, to be able to actually put yourself outside of the moment. And last is flexibility. Shit happens, you can deal with it. So if each of you look at that yourselves, think about how do you fare on the flexibility, on the self-actualization scale. And for myself, balance is key. So why are we here? We're here because we're learning about addiction. And the definition of addiction is a chronic pattern of behavior that is characterized by the repeated use of substances or a behavior despite significant ongoing harms associated with its use. This next slide I'm going to show you was a mind blower for me, because the idea is you have patients sitting in your office, and how do you know if they're struggling with addiction? And like any medical condition, it's a spectrum. And so what I'd like to do right now is kind of go through that spectrum with you and explain what it means to be, say, non-use to habituated to addiction. So on the one end, we have a non-user, someone who is not interested in using, may never use. So I think all of us at one point can relate. Some of us still can relate to that. And then, maybe one day you decide, I want to experiment. Now, for me, this was New Year's Eve, 1996. I actually thought about this last night. I'm like, wow, it's been almost 20 years since my first use of MDMA, ecstasy. And it was at a circuit party in Toronto. It was amazing. I had my first experience with MDMA. It was amazing. I connected with everyone. That was me experimenting. Wasn't an addict at that point. I experimented. And then 2 months later, I went to a second party. Experimented maybe, or maybe it was more recreational or social use. And so what happened in that first couple years is I started going out and partying every once in a while with MDMA, with ecstasy. And for me, it was fun, it was social, it was with friends. And I think a lot of us in here, maybe not a lot, many of you in here probably have done that, been at that point. There's a lot of judgment and a lot of shame that comes with that. What happens after this is sometimes habituation can happen. And I think this plays a role with a lot of cultures. So when you have someone sitting in your office and they tell you that they have 2 glasses of wine at night, are they addicted? Are they someone struggling with addiction? Maybe not. Maybe they're just habituated. Maybe they can still get up in the morning, maybe they can still go to work, and maybe there's really very few negative consequences really in the short term. You know, we know diabetes, we know heart disease, we know all of that stuff plays a big role. But in the short term, maybe there's not much. What happens when you're in this habituated use? It's a warning sign. Because guess what? Life changes. People die, relationships change, and individuals that are stuck in that habituated pattern have the potential to progress into abuse and addiction. The difference between habituation and abuse is that abuse has negative consequences. They're missing work, they're missing family stuff, but at that point, they haven't tried quitting. There's no compulsion yet. There's no desire to want to quit. So for me, what happened when I went from abuse, when I started missing work and stuff, I tried to quit. In that moment I decided to stop, I was an addict. Because I tried and I couldn't. And that's truly the definition of addiction, is when someone actually tries to stop and they can't. When someone tries to get high and they need to use more and more. There's a buildup of tissue tolerance. There's a physiological and a psychological tolerance that develops. So use the spectrum when you're working with your patients. Really, I think a lot of us see people in the habituated pattern, but if there's no real negative consequences, short-term negative consequences, maybe they haven't hit the abuse stage. But if they tried and they keep failing, and they've tried and they keep failing to get sober, they're probably struggling with an addiction. And so I got to be very careful of the terminology that I use, because terminology is itself stigmatizing, and I'm not perfect at this. Just like I try to say naturopathic doctor and naturopathic physician, not naturopath. I try to say someone struggling with addiction, not an addict, not a junkie, not an alcoholic. So that's important for me to say to you guys, because I was once someone struggling, didn't reach out, and if I heard friends or family talk about this, I didn't want to reach out to them. Likewise, as colleagues. You know, we're talking to our friends. If you have a friend sitting there struggling and they know that your thought on addiction is that, you know, these are alcoholics or crackheads, maybe your friends aren't going to reach out to you. That's a problem. I had this wonderful idea of putting all these great terms on here, but then guess what? I realized that I was bored with the slide. So there's 2 definitions on here. Psychoactive drug, not a big brainer, you know, it makes it kind of changes your psychology. Harm reduction is something that is very controversial. Now, we live in an amazing city, an amazing province that actually leads the way around the globe on harm reduction. We've got Insight Safe Injection Site, which has paved the way for injection sites across Canada. We've had the U-Brew program, which allows individuals that are living on the street to brew their own alcohol, so they're not stealing money or robbing people for it. We've got crack pipe exchange programs. We've got heroin injection programs instead of methadone-based programs, which is also a harm reduction program. So there's a lot of harm reduction happening here in Vancouver. But there's also a lot of, there's 2 sides. There's a camp that's complete abstinence and believes that in order to actually truly heal addiction, you must stop all substances. And I agree with that. And I think the goal of harm reduction is to eventually become abstinence, but it's not a necessity. Because guess what? People can be productive people in the society even if they're struggling with addiction. And it's about finding a way that we can work with them on that. So a couple years ago, 2013, the DSM-4 changed to the DSM-5. There were some changes with that. For you guys right now, if you're looking to, under your assessment, under your SOAP notes, diagnose someone with a addiction, it's actually called a substance use disorder. So I write SUD and hyphen or alcohol, cocaine, tobacco. And the idea is with a substance use disorder, you list all the substances that they are addicted to. You could write it as an alcohol use disorder, a cocaine use disorder, or a substance use disorder, alcohol, substance use disorder, cocaine. What they've done is there's 11 criteria. So a person using larger amounts than intended. If that's true, check. Unsuccessful efforts to cut down. Excessive time to obtain, use, and recover. I think in my full throes of my addiction, which was 4 years ago, so I actually went into rehab 4 years ago, actually right now, and I tried so often to cut and quit, and it just didn't happen. And so, I mean, if I actually went through me on this, I probably would have scored a 10 out of all these criteria. So I'm not going to read them all, you've got them there. But the importance on those criteria checks is that if you check off 2 or 3 of those, then it's called a mild substance use disorder. If it's between 4 and 5, it's a moderate substance use disorder. And a severe would be 6 or more criteria. There are some qualifiers that you can add on to that. Early remission is someone who's actually in recovery, who's actually in early 30 days recovery, and someone who is in recovery would be a year out. So for myself, substance use disorder in recovery. The DSM-4 change, they pulled out any of the legal criteria. It was actually quite discriminatory to actually have legal issues in there, because what it was doing is was actually capturing, especially in the States, some of the lower socioeconomical class, and it was deemed prejudicial, so they pulled that out of the DSM-4, out for the DSM-5. Different models of addiction, different theories on what causes of addiction. I think the moral model has been one that has been around for a long time, and that there's some moral failing in a person that causes them to reach out for addiction, and therefore something morally is wrong with them. And I don't know if that actually does much to help anyone in their self-esteem and help anyone get out of addiction. So I'm not a big proponent of that. I would say the medical model and some stress model are the ones that I believe in, and that's disease of an addiction is chronic, progressive, recurring, incurable, and potentially fatal. And there could be some genetic irregularities in that. So everyone's going to have their own idea on this. I think the disease model, the medical model, is the biggest one now. The Canadian Medical Association in 2006 actually announced that addiction is a disease. So before then, addiction was not considered a mental illness. So it's only been actually less than 10 years that it's been clumped together, and resources have increased, and funding has increased for that. Why do people develop addiction? Well, there's individual-based things, genetics, physical mental health issues. Of course, we know environment can play a role. If you're in a household with a lot of drugs and addiction, well, guess what? You're at an increased risk of struggling with that yourself. And there's some other summaries of risk here that you're welcome to take a look at. I've put a few of these studies on here. You're welcome to look these up. If you're interested in looking at what the genetics says about addiction, there actually shows some strong ties in there. If anyone's used 23andMe, there's some great SNPs that you can get out of that for the dopamine receptor 2 and the COMT, and there's some really great SNPs that you can evaluate and use as tools to help your patients. But I hope at the end of this talk, it's not about which IV do I give them, what supplements do I give them, it's how do I have that conversation, and how do I help support them. When it comes to a modality, I think counseling is probably the most useful tool when it comes to addiction. So we talk about the accumulation of losses. So what does a person go through over time when they're struggling with this addiction? And there's isolation. I know that was for myself. My addiction turned from going out and being with friends and being debaucherous out in the community to being at home and doing it by myself and having no one know about this. And that's where it became a big issue. So there's spiritual loss, there's mental illness, there's chronic illness, severe health problems. Tolerance is really when you need larger and larger amounts. We talk about tissue dependence, and that's really a physiological dependence where the body adapts due to a long-term use of a substance. We talk about psychological and physiological dependence, and almost every substance out there has both. There is one substance that actually does not have a psychological dependence. Well, it's questionable what it does or not. And those are benzodiazepines, because they're slower acting, there doesn't tend to be so much a psychological dependence as there is a physiological dependence with them. And I will say, a question actually out here. How many of you in here, with the raise of hand, believe that the most serious addiction and most damaging and threatening addiction to withdrawal from is heroin? How many would say alcohol? How many would say benzodiazepines? How many would say GHB? So those last three are the most serious. Heroin can be, but generally not as life-threatening as alcohol or benzodiazepines. Individuals that come to your office that are drinking 6 to 10 beers a day, have had a history of seizures, you will not be managing them in your office. I do not manage them in my office. That is medically managed. They need to be on benzodiazepines, not GABA, not a herb. They need to be on benzodiazepines to prevent the delirium tremens and the seizures. Of course, this is in my opinion. In withdrawal, the body's attempt to rebalance itself after cessation of prolonged use of psychoactive behavior or compulsive behavior. So I'm not going to talk about the neurobiology of addiction. It's really fascinating to me. I'm not going to be talking about the neurotransmitters. I will be holding some webinars if you're interested in that, and I will tell you about that in a bit. I think the big thing is as naturopathic doctors, many of us know about the neurotransmitters, the building blocks of neurotransmitters. These are the main ones that are the neurotransmitters affected with mental health and addiction. And for addiction, it's dopamine. There's actually an interplay between dopamine and serotonin. So while dopamine is the, I'm thirsty, I'm hungry, get your ass up and eat some food, it's what keeps us surviving as cave people. We needed dopamine. It's the serotonin that's like, oh, okay, I'm better, I've eaten, I'm much happier with that. So it's always an interplay between the dopamine and the serotonin. Has anyone heard of the book Biology of Desire by Dr. Lewis? He's a neuroscientist, and he actually has this revolutionary idea of addiction, and it kind of goes against the medical model. And he says that addiction actually isn't a disease of the brain. And it's really interesting, and his theory is that from an evolutionary perspective, our brain is meant to become addicted because that's how we survived. And so really addiction is an adaptation from an evolutionary perspective of the brain. Well, that caused a lot of ruffled feathers in the community because I think what other people read that is this isn't a disease of the brain. There actually are structural changes in the brain. There are deregulation, or there's can't remember what that word is, of neuroreceptors in the brain. There is neurotoxicity of certain drugs. There is rewiring of the plasticity of the brain. But the reality is that's actually a normal process for the brain to do. It's an adaptive process. So his name's Mark Lewis, I believe. So the question is addiction a chronic disease? And so what I find interesting is if we compare addiction with some other chronic diseases in British Columbia, this may surprise you. Did you know that there are more people struggling with addiction than cancer? It's insane. Hypertension is quite up there. If we look at the relapse rates of other common conditions, we can see drug addiction is actually in that 40 to 60% relapse. I don't think I actually thought about relapse in hypertension, but it is. You don't take your medications, that's a relapse. Your blood pressure kind of changes around, that's your relapse. So take a few minutes looking at this. This is a really interesting diagram, and it looks at the social harm, the physical harm, and the dependence of 20 basic substances. And this was done out of a paper in the UK. There is a documentary called Bevel Up, and it will talk about this. Cat is a stimulant found in Africa. It's a natural product. They chew it and get a little bit high from it. As you can see, it's pretty low on the social harm, the dependence, and the physical harm scale. I don't think it's surprising to see heroin up there. I saw cannabis, I was a little bit surprised to see cannabis as high as it was, but I mean, when I compared it with some of the other things, it made sense to me. Tobacco, I think you guys should note, huge dependence with tobacco. How many of you guys actively work maybe every week with individuals trying to quit smoking? Yeah, and it's difficult. I actually have quite a difficult time with people trying to quit smoking. It takes an average of 9 times for someone to actually quit when they try. Things like anabolic steroids, you may not think about. So when they're sitting in your office, your patient, how do you screen for them? I've left a screening thing in these books for you guys to look at. These are through the National Institute of Alcohol Abuse and Alcoholism. And so these they change. Different groups have different things. I actually have some basic questions in my office that I like to ask. And one of my first questions is, do you drink alcohol? Do you use substances? And if they say yes, and so I'll stick it with alcohol right now, I'll ask them, how many days in the last 7 did you consume an alcoholic beverage? And they'll say 5. So I'll keep 5 in the back of my head, and I'll ask them on average, how many alcoholic drinks do you have? And they'll say 5. So I'll be, okay, 5 times 5 is 25. Well, those warning guidelines would say anything greater than 15 drinks a week for a male or 10 drinks a week for a female would be considered, maybe you should look at that. So in my back of my head, I'm like, okay, this person's drinking 25 a week. Guidelines are saying I need to look at this. Then I'll ask the second question. In the last year, how many times did you black out? If they say none, that's great, but if they say 1 or more, that's a warning sign. I'm not going to ask you guys in here, but I don't think I've ever blacked out in my life. But there are people that will black out every weekend. And my question is, well, how do you feel about that? Do you think that's actually normal? And that starts the conversation. So there's different tools that you can use in your office to assess someone's addiction to a substance. I like to ask the last 7 days, how many days, on average how many, and for men above 15, I go a little bit further. For women above 10, I go a little bit further. Now, if I've got a woman who's 200 pounds sitting in my office, 10 maybe not so much. Likewise, a male who's 80 pounds, I probably wouldn't think that, I would think maybe 10 was too much. So keep in mind your patient's body type does say something for that, as does their ethnicity. Redheads actually have a quicker metabolism, so they can usually handle it a little bit more. For blood evaluation, how do you discover someone who's struggled with addiction or has some damaging effects? Well, the big ones are the MCV, greater than 96, GGT, AST, and ALT. So a 2-to-1 ratio of AST to ALT, boom, that's alcohol. If you have GGT with no other biliary-based issues that's elevated, probably alcohol-related. There are a few questionnaires out there, the audit, which is used for alcohol, the CAGE questionnaire, which I think I probably learned in school. You know, C is, what is C? I don't remember, but A is, are you ever get annoyed by someone talking about your addiction? G is, you feel guilty of your drinking. E is, do you ever wake up and need a drink? And figure out C yourself. I can't remember right now. Have you ever felt the need to cut down? Thank you. So my work with Edgewood has been pretty cool. I did their intensive outpatient program last year. They offered me to come do it with the idea that after I went through the program, I would help implement some more naturopathic nutrition-based services within the program. And they work really well with the American Society of Addiction Medicine. And the ASAM has created different dimensions that you evaluate your patient on to see whether or not they are meant for inpatient-based services or whether they can do some just basic counseling. So it's basically a triage. And this is called the EASY. This is created by Edgewood. I've been given permission to use this, so I lecture with this in my Project Starlight. It's a booklet that covers the 6 dimensions. There's questionnaires that you can work your patients through. I will say as naturopathic doctors, I think we have a step up. I think our general charts, we can figure this out on our own, but these are meant for counselors and other individuals in the addiction field. So we'll look at what's your history of acute intoxication? Have you ever had some serious withdrawal effects? If you have, then that's probably going to leave you on one continuum. All the way down to what's your recovery environment like? When you are at home, does anyone else use substances around you? Are your friends using substances? And so maybe going to home, doing outpatient living at home isn't going to be the best option for you because you're not going to be in a supportive environment. If anyone's interested in learning a little bit more about these 6 dimensions, it's all over the ASAM website. I've also got this book up here. I've got it digitally, so you can send me a message and I'd be happy to send that to you as well. This is a really cool continuum of care, and they triage it at a level 0 to a level 4. And so level 0 would be nothing, and 0.5 would be early intervention. So that's someone in your office that you think is having some struggle with addiction, and you may make some suggestions for them. So it's not very much. You don't think it's very serious. It may just be a suggestion like, hey, you know, you're drinking alcohol every night, which is fine. You know, that's within your culture, but just keep in mind that if things happen in your life, this could change. So keep me up. Let's have conversations about this. To outpatient services. Outpatient services are when an individual can live at home. So they don't have to quit their job necessarily. They don't have to really separate themselves. Maybe they've got family. Maybe they're in a supportive environment. And they just actually live at home, go to work during the day, and they may have a number of hours that they need to do in certain addiction type services. So when I went through my rehab, I did outpatient. I did 10 hours a week plus some additional stuff. So every week I had different things that I had to go do, and it worked for me, thankfully. But I didn't have someone using at home. I had supportive family, and you know, I'm surrounded by some amazing people in this profession. But someone who doesn't have that may require inpatient treatment. And so inpatient can be as much as having medical doctors there every day and nurses there every day. So that would be like a level 3.7 to 4.0. These people are in severe detox. They need help. We have very few of those here in Vancouver. We actually really only have 4 medical detox facilities in Vancouver. That's less than 50 beds. And I'll say it's poorly uptaken by women and individuals that are not Caucasian. So it's like for white men. It's really a shame. There needs to be more work done in this community for ethnic minorities, for people that can't speak English, and for women. And I've gone to some of these sites and I can understand why. People don't feel comfortable. It's almost like a prison in a way. Quite sad. So there's a whole continuum of services here. And as naturopathic doctors, I don't expect you guys to know this, but after today, you're gonna have some numbers, you're gonna have some websites that you can send to your patients. So for medical detox, 4 facilities, Vancouver Withdrawal Management Services, this is where I'm gonna be practicing. This is where I actually did my day talks. So upstairs is a detox facility. They've got, I think, 20 beds. Downstairs, they've got a day program where people come in during the day. They've got Monday through Sunday from 8 in the morning till 8 at night. Every hour, they've got different events like communication skills, meditation, anger management, smart recovery, talking circle, art therapy, and even auricular acupuncture. They do 4 hours of auricular acupuncture every day. We've got Creekside Withdrawal Management Services for you guys in Surrey. Harbor Light, which is downtown East Side. And then how you access some of this is here in Vancouver, in the Vancouver area, we can call Access Central. So if you're down here, this number is the number that you call. Yeah, Jason.
Do we need to have do we need to refer them to self-report?
Self-referral, they can. I will say the wait list on some of these is not great. So if you know people, like I know that at Vancouver Withdrawal Management Services, if I tell my patient they go there at 7 in the morning and knock on the door, they probably can get in, even if they say they can't. Because I know that there's 2 reserved beds there. And if the hospital doesn't send patients to there, there's 2 empty beds, and they will not turn them down. Yeah, Mike.
How are these places?
Provincially, yeah. Inpatient treatment, these are private. Some of them actually have some public funding. So Pacifica, if you're on welfare, you have full funding. If you are someone who is on welfare, you can actually get support for some of these. But someone who isn't on welfare that doesn't have a lot of money, it's not so great. So we've got the Orchard Recovery on Bowen Island. Edgewood is over in Nanaimo, and they've got an inpatient or an outpatient on Granville. MRTC, which is in Maple Ridge. Pacifica on Commercial Drive. Cedars over on the island. We've got Last Door and Westminster House in New Westminster. And we've got Together We Can, Klinghaven, and Turning Point also downtown, or also in the vicinity. So these are places that individuals go in for 30 days, 60 days, 90 days or greater, and they get inpatient-based treatment. The cost for this, Pacifica, maybe $3,000 for a couple months, so not too bad, or Orchard Recovery, 27 grand a month. So as you can see, to get real support here, sometimes you have to have a lot of money. And if you don't have a lot of money, but you have enough to not be on welfare, that's where the gap is. So some of the outpatient facilities here, we've got Edgewood, we've got Homewood, and the place I went to, which was Vancouver Withdrawal Management Services, the Daytox, which is downstairs. Again, Access Central, This number here at the bottom is the number that you can call yourself to get information, or you can have your patient contact this number. It's a window of opportunity. When this window of opportunity opens, you want to get that person some help. The reality is that window closes quite quickly, and it takes an average of 3 weeks to get a person into where they need. So a lot of times those individuals aren't ready at that point to get in. So understanding a little bit how to work the system, having these numbers can help you out and can certainly help your patients out.
Do they have to be clean to be accessing the program?
Some of them, yes. But for example, these ones, absolutely not. You actually need to be actively in withdrawal to be able to do that. Some of the places are abstinence-based programs, which mean you cannot be on methadone, which means that you cannot smoke or drink coffee. Where other ones are a little bit less abstinence-based, where they'll allow you to drink coffee and smoke cigarettes, but you can't be on methadone or even antipsychotics. So there is a big paradigm shift between the abstinence-based camp and the harm reduction-based camp, and it's because of funding. The government gives funding to these two camps, and it's a fight. I'm harm reductionist. I have battles with Edgewood all the time because when I was in IOP, I'd see people with their cigarettes underneath them, but they wouldn't let someone in because they were smoking marijuana. And I'd argue, I'm like, tobacco is probably more harmful than the marijuana smoke they're eating. And it's really, and their answer is, Aaron, if we actually said you couldn't smoke cigarettes, we wouldn't have people coming here. And I'm like, oh, it's a money thing. So unfortunately, that's what it is. Okay, I've got a few minutes left. I'm gonna follow a few of the main things here. Some addiction group support services. So if your patient is struggling with addiction, it's not enough for them just to see a counselor and to see you. They need to find a group community. And it doesn't have to be the AA community or the NA community. And even if you're not spiritually based, guess what? You don't have to believe in a God to necessarily do these. They've got agnostic AA. They've got Gamblers Anonymous. They've got Cannabis Anonymous. They've got all these different types of anonymous. And the great thing about them is they have sponsors. They've got people that have been through it. I work with Smart Recovery. They're a science-based model. It's all about coping and triggers. There's no peer support with that. And then LifeRing is another one which brings in a little bit of that peer support where you go there, it's a group support, and you meet someone who's been through similar type experiences. So here's a bunch of the websites here for you guys to look at. I'm going to leave with this closing, two slides I'm going to show. This was by Brian Day. This is 2007. This goes to show the change in how addiction was looked at. And it's not unlike mental illness. There exists a negative view and stigma around addiction, that these members of society are somehow weaker than others, that it is acceptable for us to turn a blind eye to their suffering. It's time to clear the air. Addiction is a disease, and those who suffer with it need medical assistance, just as those who suffer from heart disease or cancer. So, in closing, there's some pretty cool stuff going down the pipeline. And working on the BC board, I've been working with the Canadian Mental Health Association to get naturopathic doctors involved. And believe it or not, they haven't really recognized naturopathic doctors. And I just heard from one of the ladies that works at CMHA yesterday, and we're working back and forth to start a pilot project for naturopathic doctors to be working with psychologists to be able to work on this campaign, which is before stage 4. Because, when we talk about cancer, we're really good at preventing and finding early cancers before it hits stage 4. But when it comes to mental illness, we don't do a good job. We're often finding people that have hit stage 4. And guess what? We need to do a better job of finding these preconditions where people are suffering. So, I'll be here after the talk. You guys ask some questions. Mike, a quick one?
Just briefly, if you could, what are some of the naturopathic things that you do in supporting these areas?
As a modality,
Yeah.
counseling. So I love it when doctors are like, Aaron, which IVs do you do? I want to do these addiction IVs. No, because guess what? You can do more harm by just taking a person, putting them on IV, and letting them go. You need to connect them with community. So this talk isn't about what herbs and vitamins that I use, because that's not where we're at. If you're not actively involved in the community, you need to start there first. Yeah, Jason.
So, I had this new patient this week who basically got cirrhosis. He's coming because he wants to be able to have a liver that's healthy enough to drink again.
Yeah.
So, I guess the question is, like, say you assess a need and the person really isn't in that space of that window opening.
Yeah.
What are kind of some of the things that you would do?
For me, it's all about self-esteem of a person. Because if a person's got a shitty self-esteem, whatever they're in is going to swallow them. So it's okay, you know, maybe you want to get better. So if you're going to drink, space your alcohol with a big glass of water. Harm reduction. It's all just like, how can we take little baby steps to get you drinking less next day? Or doing something to help protect your liver. So I'm meeting a person with where they're at. I'm assessing where their self-esteem is, because there's going to be no change happening when they're hitting down here, when they're bubbling in the shame and the guilt.
So I guess the other flip side of that question is like when you start planting seeds, then have the person start thinking.
Every day. All the time. Yeah, always planting a seed, but never pushing. Never pushing. Alrighty, I want to give Steven a chance to come up here, so I'll be around, guys. Okay, see you guys, Facebook.